Hello. So in today's class, we are discussing the relationship of the mandibular rest position to its habitual occlusion. That is how the mandible moves from its position of rest to its position of occlusion. The mandibular movement could be pure rotational, that is a hinge movement, or a combination of rotation and sliding, maybe anterior or posterior or lateral sliding. So it is important to assess this mandibular movement or the path of closure from its position of rest to its position of habitual occlusion three-dimensionally, that is in all three planes of space.
So the mandibular path of closure is observed three-dimensionally in the sagittal plane, the vertical plane and the transverse plane. So in the sagittal plane, the two extremes of malocclusions which are observed are class 2 malocclusions and class 3 malocclusions. Coming to class 2 malocclusions, which can be clinically observed with an increased OJHEP with the maxilla and the maxillary dentition ahead of the mandible and the mandibular dentition. So as we observe the mandibular movement from its position of rest to its position of habitual occlusion, you may find that the mandible may move like a simple round arc without any gliding or sliding movement. This type of movement is known as rotation without sliding. This kind of mandibular movement occurs in true functional class 2 malocclusion. The mandible moves from its rest position to its habitual occlusion in a simple round arc without moving ahead or behind during the movement. Another type of mandibular movement which can be seen is posterior gliding. The mandible first glides posteriorly from its position of rest and then it is guided into an occlusion which is much posterior to the position of rest. See, when we observe this rest position of the mandible, we see that it is a normal class 1 occlusion. But the mandible is glided posteriorly and is guided into a posterior occlusion which seems to be a class 2 malocclusion. This type of class 2 malocclusion is not a true class 2 malocclusion owing to the position of rest of the mandible which is a class 1 relationship. This type of class 2 malocclusion is quite favorable when treated. Another type of movement is rotation with anterior sliding. The mandible may rotate for some time and is guided anteriorly into a habitual occlusion. So in habitual occlusion it is already class 3, but when you examine the rest position of this mandible, it is further towards class 2, that is further the mandible moves behind the maxilla in rest position. This type of class 2 malocclusion is more pronounced and it actually occurs clinically. Coming to another extreme in the sagittal plane, that is the class 3 malocclusions, as you observe the mandible from its rest position to its habitual occlusions, you would be able to see different types of mandibular movements. One of it is pure rotation, that is rotation without sliding. The mandible moves from its point of rest to its habitual occlusion in a pure rotational movement without sliding or gliding anteriorly or posteriorly. This form of class 3 malocclusion is again a true class 3 malocclusion. You may observe the mandible moving posteriorly from its rest position and then attaining a habitual occlusion position which is still a class 3 malocclusion ahead of the maxillary incisors. So this posterior glide can be seen when the mandible wants to attain some occlusion, and it may cover a true sagittal dysplasia. Why? Because when you see the rest position of the mandible, it is much ahead than what is seen clinically in the class 3 malocclusion. So the true sagittal dysplasia which is seen is actually observed in the rest position of the mandible, which is much severe than that can be seen at the habitual occlusion position clinically. The mandible may also slide anteriorly sometimes and gain a forward position. This forward position, when compared to the rest position of the mandible, it may seem as a class 3 malocclusion, but when you observe the rest position of the mandible, it clearly is a class 1 relationship between the maxilla and the mandible. This was rotation with anterior sliding, which is not actually a skeletal class 3 malocclusion.
Next assessment is in the vertical plane, and it is important to analyze the vertical space that lies between the maxillary and the mandibular teeth when the mandible is in rest and in occlusion. A small freeway space which is characterized by a less amount of space between the maxillary and the mandibular teeth when the mandible is in its rest position. It is characterized by over eruption of the incisor teeth and often called as a pseudo deep bite. Finding of a large freeway space is often characterized by under eruption of the posterior teeth and is called a true deep overbite. As we know that the freeway space is the space between the maxillary and the mandibular teeth as the mandible attains a position of rest. It is important to know any deviations in this freeway space and the cause of such deviations in order to devise a suitable treatment plan for the patient. Coming to the third dimension in the transverse plane and observing the patient from the front and at the eye level, coming to lateral occlusion. As the mandible moves from its position of rest to its position of occlusion, the mandibular midline is closely observed from the front. If it happens that the mandibular midline is deviating from its position of rest to its position of occlusion, it is recorded. If the mandibular midline and the maxillary midline are coinciding at the rest position while it is deviating in habitual occlusion, it is known as lateroclusion. If the mandibular midline and the maxillary midline are deviated to the same extent in the rest position as well as habitual occlusion, it is called as laterognathia. That means it is a skeletal malocclusion, and lateroclusion means a functional malocclusion, that is, in the rest position, the mandible and the maxilla are coinciding in the midline, but when the mandible goes to the habitual occlusion, it is glided maybe because of a premature contact to a position which is laterally oriented. So when a crossbite is seen clinically, it is important to differentiate and find the cause of this crossbite, whether it is just a lateral occlusion because of some functional irregularity or a premature contact, or it is a laterognathia, which is a true lateral relationship between the mandible and the maxilla.